Hello guys, hope I'm audible and visible. Hi. I hope today I won't have any tech issues. The first time it was a performance anxiety for the technology, right? It didn't work through. And I hope we will swim through good in technology as well as good in pathology today. I think I'm live. Okay. If you can listen to me and if you can hear me, just say hi or yes or present or whatever you feel like, right? So let's start today's session. We did see yesterday about all the required things about the cellular adaptation, right? So I'm going to continue with that. Good evening, everyone. I'm going to continue with that. I'm going to go with cell injury and necrosis, right? So, like yesterday, I will have the same flow. Only one thing which is left in cell adaptation, we'll do that first atrophy. We'll also apply in few questions. We'll see whether our application skills is more. Since you're in second year, and most likely you might be giving the next exam. Maybe I don't know when it's going to happen. So I want you guys to get accustomed to solving MCQs a little bit early than late, right? So we'll apply that and definitely we'll learn from that. Good evening, everyone. Fine. Okay, great. Ready for the day? And today's competencies which I'll be covering as per your CBME curriculum. I'll be talking about the etiologies of cell injury, distinguishing between with reversible, irreversible cell injury, the mechanisms of cell death or the damage happening, and the morphological changes in microscopy, what all changes I can see. Then we'll talk about cell death. There are two major types of cell death, necrosis and apoptosis. Today, I'm going to talk majorly about necrosis. Maybe in the subsequent sessions, I'll talk about apoptosis as well and other forms of cell death also. Fine. So these are two competencies we'll be covering in today's lecture, right? Like I said previously, we did the three cellular adaptations: hyperplasia, metaplasia, and your hypertrophy, right? Let's see how good your listening skills were and did you read after going back after the class, right? Just a test. All these cell adaptations, they are reversible or irreversible. The cell adaptations are reversible or irreversible. Just comment whatever comes to your mind. One letter is enough. I don't want you to comment, type everything and waste time here. All these cell adaptations are perfect. They are reversible, right? What is the most common example of metaplasia? Just to recollect whatever we read yesterday, that's all right. Fastest finger first. The most common example of metaplasia: smoking induced respiratory or GRD induced Barrest. Perfect, Chris. Smoking induced respiratory tract, right? Perfect. Am I right in saying that hyperplasia increases the risk factor for carcinoma? Yes or no? Just comment Y or N. That's all. Hyperplasia, there's more risk of carcinoma's transformation. Yes or no? Absolutely. Yes, right. Endometrial hyperplasia can result in endometrial carcinoma, right? Next question. Let's say a patient is having pulmonary hypertension. What type of hypertrophy will I see? Concentric or eccentric, and in which chamber of the heart? Right ventricle or left ventricle? This is more important for us to understand whether you understood the concept, grasped it, and you are able to apply it. In case of pulmonary hypertension, which ventricle will be involved and what type of hypertrophy you will see? Perfect. I'm sure you guys are smart, right? You guys are smarter than you think you are, right? You're amazing. You know that. It's a example that you have understood the topic. Pulmonary hypertension will be involving the right ventricle, and the right ventricle will have your concentric hypertrophy because it's a pressure induced hypertrophy, which will be throughout the ventricle, right? Perfect, perfect, great. So we are good to go. Systemic hypertension will involve the left ventricle, and pulmonary hypertension will involve the right ventricle, right? That's different. Systemic hypertension to aorta, the right ventricle pumps against the capillary venous pressure, all the pulmonary hypertension, right? It's the right ventricle and the concentric hypertrophy of heart, right? Okay, with that note, let's go on to atrophy. What do you guys think about atrophy? What comes to your mind? Even in your embryology, even in the first year, you must have learnt about an organ which is present in children. When we grow as an adult, it disappears. That organ is in mediastinum. What organ is that? Okay, always you say everything is there in the name. It's atrophy. Atrophy is growth. A is absence. It's absence of growth or reduction in the number of cells as well as the size of the organ, right? The first important thing, the organ is thymus, right? Perfect. Thymus will undergo atrophy. Yeah, I'm sure everyone must have heard this. In an adult, thymus undergoes atrophy for sure. None of us has thymus now, right? It was there when I was a child, but it underwent atrophy. Perfect. So atrophy, the first and the only thing I want you to remember forever is atrophy is an gross terminology. It's a gross term. It's not a microscopic term. I don't look at the microscopy and say there's atrophy. It's cell death I call it apoptosis, or I have some more findings which we'll see soon, right? It's a gross terminology, it's not a microscopic terminology. Now, you guys only said that thymus undergoes atrophy. Am I right in saying the thymus will come back in adult life? Is this statement right or wrong? Maybe after 20, 30 years, thymus comes back again. Will it come back again? Yes or no? No. So can I say atrophy can be irreversible? Is that statement right? It is right, right? So always the exceptions are important for me. Atrophy can be irreversible. I'm not saying all atrophy, but definitely I'm sure that you also will accept that thymus will never come back in adult life, right? Atrophy can be reversible, also can be irreversible. See, exceptions are always important for you. It'll never come back, right? So exceptions are always very, very important for me because no one is going to ask you the routine thing. The exception is what excites them, and I want you to remember that. Perfect, right? Can be irreversible, right? Now coming to the definition, atrophy means decrease in the cell size and the decrease in the size of the organ or structure. If I'm going to talk about thymus, I'm going to call it an organ. If I'm going to talk about a muscle, I'm going to call it a structure. That's all right. So the easiest way to remember the cause of atrophy is there are few things which are very, very essential for my cell. When that is gone, automatically my cell undergoes atrophy, or the cell decrease in size, or reduce in size of the organ, right? So tell me, what are the things which are important for a cell to live? A cell needs to live, right? A cell is living. What all thing you do you think is required? Can I say blood supply is definitely essential for a cell? For oxygen supply, it is, right? I can write that blood is definitely essential for a cell. Second, am I right in saying that a cell should function? If it doesn't function, automatically it goes to death. In other words, let's say that I'm not using this limb for 2 weeks, 3 weeks. The muscle becomes smaller for sure, right? Post fracture, if any one of you has had a fracture, you had a POP cast, 3 weeks, 6 weeks, you don't move the limb. When you remove the cast, the limb will become smaller. That is disuse atrophy, right? I need to, this organ should be functional. If the function reduces, automatically it undergoes atrophy. Third, can I say that a cell needs protein for survival? Protein is must for survival, right? Nutrition is must for survival. When there's a nutritional imbalance, I'll have atrophy. These are all required for a living cell, right? Four, we yesterday read about our endometrium. Am I right in saying that I need hormones for endometrium to have a normal growth? I need estrogen is required, progesterone is required, everything is required, right? So not every organ, but there are few organs where hormones will be required. There are few structures where it require nerve supply. Nerves are very important. Without my nerve, my muscle won't move. Without nerve stimuli, my esophagus won't contract, right? Everything requires a nervous stimuli, right? There are quite a few things required for me. Not just that, every cell needs space as well. I need a space to live. I'm here, you are there, you need a space. If the space is not there, obviously I'll be shrunken, I'll be constricted, right? So these are the things required for a cell to live. If any of these are going to become reduced or lost, I'm going to have atrophy. That's all, right? So when there's blood reduction, we use term ischemia, right? I'm not talking about the ischemia in a pathological condition here. Am I right in saying that every one of us in the near future, maybe 50 years, 60 years down the road, you will have atherosclerosis in the blood vessel invariably? You might not have a heart attack, but definitely you'll have atherosclerosis. If there is atherosclerosis, am I right in saying that the blood supply automatically will reduce? It will reduce, right? So over the period of time, even in old age, when there is atherosclerosis is nothing but the blood vessel becomes thicker and becomes smaller. Because of this, there'll be a less blood supply. If the blood supply is less to the CNS, I call this a senile atrophy of the brain. Okay, there's a senile atrophy. Due to the age, automatically it undergoes atrophy. That's a senile atrophy of brain, right? It's normal. Every person's brain will atrophy when you reach 80 or 90. That's why maybe your grandparents might not be able to remember things properly. You guys also not able to remember things properly, right? Your brain is perfectly fine. It's not having any atrophy at all, right? So senile atrophy is, I cannot stop it. It'll definitely happen. But the same atrophy happens in, let's say, 35-year-old person. Normal, abnormal. Same senile atrophy happening in a 35-year-old adult. Perfectly normal adult. Brain undergoes atrophy. Abnormal, right? Perfect. Abnormal atrophy of the brain parenchyma. Can I say the patient will not be able to remember things? Is that statement right? So what disease I'm talking about here? What disease I'm talking about here? Senile atrophy can happen in any organ. One of the important organ for me is brain can undergo senile atrophy. It's not just the normal physiological atrophy. It's abnormal atrophy also can happen. We have the disease called as an Alzheimer's disease, right? It's not just here. It's not just to old age. I can have pathological atrophy as well. Pathological brain atrophy. It happens in. I'm sure you must have heard about disease called as Alzheimer's, right? Perfect. The Alzheimer's is an early age atrophy. 90 years, if the brain is undergoing atrophy, I don't call it Alzheimer's. It's normal aging. That's all. 35, 40, 50 undergoes atrophy and they are forgetting things. It's due to Alzheimer, right? That's abnormal for me. Perfect. We'll come back here again. Function. Like I said, every organ needs to be used. I have something called an disuse atrophy. The best example, what I think of disuse atrophy is the fracture. Post fracture, this is the symbol for fracture. Hashtag the symbol for fracture. Post fracture, we have a plaster of Paris cast. The white color cast you put, right? That's called a POP cast. Once you put a POP cast, you don't move the limb for next 6 weeks. When you remove it, automatically it will undergo atrophy. That's disuse atrophy. Any organ you don't use, it undergoes atrophy. Sahil, Huntington's chorea is a different condition. It's due to mutation. We'll learn them when we come to genetics chapter. Fine. Okay. Nutrition. You are going to give me an example for nutrition-induced atrophy. They are pathological only. Am I right in saying that in your biochemistry, you must have read about PEM, protein energy malnutrition? Can you guys give me any one example of PEM? There are two major causes of PEM, protein energy malnutrition, kwashiorkor and marasmus. Right? When protein energy malnutrition happens, kwashiorkor and marasmus are standing examples of atrophy. I am sure in biochemistry you must have seen the image of the kids, extremely thin limbs. Limb is reduced in size. Reduction in size of the organ or the structure is nothing but atrophy, right? The kwashiorkor marasmus, classical examples of nutrition-induced atrophy, right? Hormones. Like I said, hormones are very, very essential for functioning of few organs. One of the thing what we read yesterday was the endometrium. Post-menopausal, right? The women that underwent menopause. Do you think the hormones will function? Ovary is not going to function. Hormones will not be there properly, right? So post-menopausally, am I audible, visible? Yeah, I am. Okay. So post-menopausally, what happens is you'll have atrophy of the endometrium. That is hormone-induced atrophy. Postmenopausal atrophy of endometrium is hormonal induced. Postmenopausal atrophy of the breast parenchyma is hormonal induced. Okay. Now I want you to ask you one simple question. Answer whatever comes to your mind. In a postmenopausal woman, if I give estrogen and progesterone again, will the menstruation start forming again or no? Will the menstruation start forming again? Will the women have menstrual cycles again? No. So can I say this is irreversible? It is, right? So like I said, there are few examples of irreversible atrophy as well. I cannot reverse this. You can never reverse an endometrial atrophy. It's gone. If hormones are gone, the women's endometrium is not going to function. After that, nothing will happen. That's the limit, right? Nervous atrophy. This I'm sure you will definitely relate. You must have heard about claw hands. Which nerve palsy will cause this claw hand? What is this? This claw hand. Whatever claw hand you are comfortable with. Okay, this claw hand. Which nerve palsy will cause this claw hand? The two fingers are clawed. Ulnar nerve palsy, right? You must have definitely heard about claw hand and ulnar nerve palsy, right? When my ulnar nerve is affected, my muscles also will be destroyed. Again, in the clinical application anatomy, B.D. Chavrasya talks about this. When ulnar nerve is gone, first what happens is this hypothenar muscles becomes flat, atrophy. Because nerve is gone, muscle doesn't function, it's gone, right? We call this atrophy an denervation atrophy. Okay, we have a denervation atrophy, right? Okay, ignore the radial ulnar. I just used both the things. If these two are gone, it's ulnar nerve. If I'm wrong in anatomy, excuse me. You guys are definitely far better in anatomy than I am, right? So I call this an denervation atrophy. When my nerve is gone, definitely the muscle will be gone. It's not just for ulnar, for median also, for radial also, for your tibial also, anywhere. Anywhere nerve is cut, the muscle is gone. Right? That's denervation atrophy. Like I said, it's space-induced atrophy. It's very unique. Okay. Let's say I'm having a brain tumor, a glioma, right? I'm having a glioma in the brain, fine. When I have glioma in the brain, I'm having a big tumor in the occipital region or the frontal region. The tumors keep on growing. Tumor will not cause pain, right? Gliomas don't cause pain, right? They don't have pain. But they will compress on the adjacent parenchyma and cause lesions, right? That's called as in pressure induced atrophy. So they cause pressure induced cell death. Okay. Yeah, pressure induced atrophy, pressure induced cell death, right? So any brain tumor will not present as a brain tumor. You must have heard about optic nerves, lesions in optic nerve in your first year, right? Pituitary adenoma can compress the optic nerve and cause visual field defects, right? All those are examples of atrophies, fine. Okay, all those are examples of atrophies. Just a second, sorry. Right? So all these are things which are required for me for normal. If it is not there, it undergoes atrophy. Oop, I'm multiple and visible. Okay, fine. So all these are normal examples of atrophy. So we know everything about atrophy. So most of them here, what I talked about is pathological, maybe except for senile atrophy, which might be physiological. But let's think about, let's assume where all I can have physiological atrophy. Because if you have to write a essay question or a short note on atrophy, you need to talk about physiological as well as pathological, because people expect physiological, though it is not needed, they expect physiological, right? So physiological atrophy, one example, a beautiful example, what you guys gave, thymus, undergoes atrophy for sure. Am I right in saying that the notochords will disappear? Notochords will disappear, right? The notochord, I don't have a notochord now, but in embryology, I had a notochord. What is the, which, from which place the thyroid form? One I have from the pharyngeal pouches arches. There's one more person called as foramen cecum. Where do you see foramen cecum? In the neck or in the tongue? Where do you see foramen cecum? Neck or tongue? You see foramen cecum in the tongue, right? So from the tongue, it descends. You must have read about thyroid embryology. The descending tract is called as a thyroglossal tract. That will undergo atrophy. Adults don't have a thyroglossal tract, right? So my thyroglossal tract undergoes atrophy. Okay. Like this, I can give multiple examples. When we are in fetal stage, when we are in embryonic life, all our fingers were united. Like it will have webs in between. It will be destroyed. Once they're destroyed, I have individual fingers. That also is due to atrophy. There are lots and lots of examples for physiological atrophy, and most of them are embryonic only. Okay? Most of them are embryonic. Senile atrophy again is physiological in old age. Endometrial hormonal atrophy again is physiological in old age. Fine. These are embryonic atrophies. Right. Now I'm going to ask you a question. I want you guys to think about this and answer. I told that atrophy is both reversible and irreversible. If this statement is true, what do you think happens in irreversible atrophy? Cell damage or cell death? Which of these two is irreversible? Atrophy is both reversible as well as irreversible. So what do you think happens? Cell damage or cell death in irreversible atrophy? Perfect. Cell death, right? So it's going to be cell death in case of an irreversible atrophy. Now again, you guys are going to answer. What is the physiological form of cell death? All the physiological form of cell death happens here. That's why these are all irreversible. It doesn't come back normal because there's cell death here. Can I call as apoptosis? Perfect. So in other words, why I'm saying this is, can I say all these might be examples of physiological apoptosis also? It is, it will be. If you look at Robbins, the same example will be given apoptosis. The same example will be given atrophy. Atrophy is naked eye, gross term finding. Apoptosis is microscopic finding. That's the only difference, right? In other words, in atrophy, once I come to the mechanism of atrophy, I have two mechanisms of atrophy. One for the reversible part of the atrophy, like PEM, marasmus is reversible. I give treatment, the patient comes back to normal. Ulnar claw hand is reversible, it will come back to normal. But there are few irreversible atrophies as well, right? The mechanism of atrophy, I have two guys in the mechanism of atrophy. One for the reversible person and other for the irreversible person. Okay. The other guy for the irreversible person. It's an adaptation, right? Atrophy is an adaptation. So adaptation means I'm having a problem. I'm trying to overcome the problem. That's what my body adapts, right? So let's assume like this. I'm not having enough energy. Let's assume you're not eating food for the next 2 days. No food at all. Hostel food is very bad and you're not eating food at all. Can I say that your functionality, your energy will slowly come down? It will. The reason why you are very down or your energy is down when you don't eat food is your cellular metabolism will come down. That's why the energy comes down, right? So for reversible change, what I'm going to do is I have to devise a mechanism by which, let's say that I'm having a cell. I'm just giving a random example. I'm having, let's say, 6 mitochondria, right? I'm writing empty for mitochondria. I'm having 6 cell organelle of mitochondria inside a cell. I don't have enough energy. I don't have enough blood supply. So I have to reduce the mitochondria or I have to reduce the proteins. That's all, right? So here, when there's reduced energy or reduced nutrition, that's one of the important cause of atrophy. Automatically, I have to reduce my amount of mitochondria. There are two ways what I can do this. In your biochemistry, have you heard about something called an ubiquitin proteasome pathway? Where have you heard them? If you have heard them, where you have heard them? There are two mechanisms by which I can reduce the load on the cell. The first mechanism is ubiquitin proteasome pathway. It's there in the name. It's proteasome, which destroys proteins, right? You must have heard about chaperones. You must have definitely heard about it. I'm sure you must have heard about it. Ubiquitin proteasome pathway. The ubiquitin goes and tags. Proteasome comes and cuts the protein and destroys the protein. Right? So one way by which I can destroy my excess protein is by ubiquitin proteasome pathway. This will destroy proteins. Destroy the cell organelles. So when my cell organelles are destroyed, when my cellular proteins are destroyed, I don't want good amount of energy. I can survive even in a starved state of malnutrition. I can survive even when there's an ischemia, when there's reduced blood supply, right? That's one mechanism. The second mechanism, the first mechanism you must have read in biochemistry for sure. The second mechanism you must have read in your school days. There's one cell organelle inside my body which has the capability of eating it. Manoj, surely I will convey it to the team, fine? Tech team. Okay. Okay. So there's one organelle inside my cell which is capable of eating other organelles. Which organelle is that? I'm sure you must have heard about lysosomes, right? Lysosomes eat other cells, right? Sure, Ashish, I'll think about it, fine. So lysosomes eat other cells. So what happens is these lysosomes produce a process called as an autophagy, right? It induces a process called autophagy. It kind of eats other things, right? So once the other cells are reduced, again there is less load so that they can survive the malnourished state. It's a survival thing. It's an adaptation. That's all. Less load can definitely survive, right? It's a very simple equation. Now, lysosome has eaten, right? Let's assume this is my one organelle. My lysosome came, destroyed the organelle, digested the organelle. The lysosome cannot throw this dust material or the debris outside the body, outside the cell, because the cell is still living. It cannot throw it outside. So what happens is once I destroy this organelle, the destroyed thing also stays inside the lysosome like a dirt material. Any dirt in the life, in your real life, what is the color? Anything dirt, anything final, any dirt in my life, what color it is? Most of the dirt will have only one color, black to brownish in color, right? So what happens is when the organelles are destroyed, the destroyed organelles stay back. Okay, the destroyed organelles stay back into the inside lysosome because I cannot throw them away because the cell is still intact, right? Stays inside the lysosome, and these destroyed organelles as a color, it gives a color to brown to black in color. So these color, the brown color pigment seen in the lysosome, I give a term as lipofuscin. I'm so sure you must have heard about this pigment. a pigment called as lipofuscin. So lipofuscin pigment is nothing but a wear and tear pigment. It's a pigment seen in old age. It's a pigment seen in cell injury. Fine. Perfect. I'm having a pigment called as lipofuscin, right? As simple as that. So I have a pigment called as lipofuscin. Lipofuscin is nothing but the destroyed cell organelle by the lysosome, which I'm not able to throw it outside, right? So these are the two ways by which a reversible cell damage happens. At the same time, I said two examples are irreversible. Whenever there's irreversible cell damage, like you guys said, irreversible is always apoptosis or cell death, right? So if it's an irreversible cell damage, apoptosis definitely happens, right? It might result due to apoptosis. We'll read about apoptosis when we come to cell death, fine. So I have two mechanisms. One is reversible your atrophy, one is for irreversible atrophy. Irreversible apoptosis, simple. In reversible, I have a way to cut proteins ubiquitin proteasome pathway to reduce the load. Other is by lysosome, which will eat the excess cell organelle to reduce the load, right? Perfect. So now my question is microscopy. Our goal is to diagnose the microscopy, right? That's why, like Sahil said, that we use the term brown atrophy. For heart, especially, we use term brown atrophy, right? Term used, not useful for diagnosis, but it's a term there. Just remember that. My goal is always microscopy. How I'm going to identify them. Let's take a heart tissue only. In a heart tissue, let's assume I'm having a cell like this. Okay? Heart is an mesenchymal cell, an elongated spindle shaped cell. I have a nucleus like this, right? A nucleus. Nucleus is always blue in color. So lysosomes are always located in the paranuclear space. That's the normal location of lysosome. Any lysosome in the body will be definitely located in the paranuclear space only. Fine. Fine. It will be located in the paranuclear space. So what happens is here somewhere I'll have the pigments. The lipofuscin pigment location is very important. They'll be seen in the paranuclear location. Okay. It'll be seen in the paranuclear location only. Always will be seen in paranuclear location. Why I wanted you to remember this is, can I say iron or rust? You must have seen rust in your real life. What's the color of rust? Normal rust in your life, what's the color? That also is brown. So can I say if there's an iron accumulation inside a cell, that also will be brown in color? That also will be brown in color. I need to differentiate them. If it is lipofuscin brown in color, it will be on either sides of the nucleus. When I say para, it's on either sides of the nucleus, on both the sides of the nucleus. That's paranuclear location, fine. That's a difference. If it's higher, it will be uniform. It won't have a particular location, right? Since there are multiple other brown colors, I want you to remember this, the paranuclear location, right? Those are things about atrophy. We know what is atrophy. What are the etiologies of atrophy? We know the physiological, we know pathological, we know it's reversible, we know it's irreversible. We know the microscopy and mechanism as well. Fine. Look at this. This how an atrophied organ looks. That's a beautiful atrophy thing, right? That's an atrophy. What is this pigment? This is a heart biopsy. This is an image from Robbins. What's the color here? That's brown in color, right? That's definitely a brown color pigment. Sorry. That's a brown color pigment for sure, right? And what structure is this? I want everyone to comment for this. Tell me what structure is this? The ones I'm marking in red color. What structure is this? I'm sure you guys will know it. What is the structure? Everything is blue in color. My thumb rule says that if anything is blue in color, I'm going to think of nucleus, right? Perfect. All of them are nucleus here. And the pigment which is seen on either sides of the nucleus. See, I'm having a nucleus. I'm having a pigment on the side of nucleus. That's my lipofuscin, right? So that's your lipofuscin pigment here. It's just a simple brown color pigment. That's all. Fine. Okay, I'm sure you can easily appreciate the lipofuscin as well as you can look at the nucleus here, right? Perfect. Great. That's about atrophy. So we are done with all the four cellular adaptations. So no, nothing ends without an exercise. That's very important. I know something, I understood something. Let's see and apply whether your understanding is right. Whenever I put MCQs, I'll make it sure that they are scenario based MCQs. I am not for one-liners. You definitely know one-liners, and I'm not here to teach one-liners for you, right? Read this question, comment on the answer, then we'll discuss. Read it slowly. You need not be in a hurry. Please always remember, any question I put here, it's not the first person whom I'm worried about. It's the right answer which I'm worried about, right? Take your time, 45 seconds of your time, answer the question, and then we'll comment on it. Whatever comes to your mind. I hope the options are visible and the question is visible as well. Okay, let's discuss. Anyone wants to comment answer? It's A, B, C, or D. Anything you answer, you have 25% of chance of getting the right answer. So don't worry about an answer. Comment on whatever comes to your mind. Let's read through the question. See, I will highlight the important keywords here because these keywords are the one which you have to search in every question. That is enough for me to solve the question. The question starts with a bone marrow cell, and there are four options here. I don't want anything else in this MCQ. We learned yesterday about bone marrow. We learned as hyperplasia or hypertrophy. It's a very simple question. I have made the question very simple. Now at least you comment. It's bone marrow. Bone marrow will divide in response to anything. So bone marrow will have hyperplasia. I didn't even read about anything in the question. It's not about reading the four lines. It's about reading the keywords. We'll go to the other keywords as well, right? So the bone marrow as cultured in so and so finding with recombinant erythropoietin. I have a stimulus there. I'm putting erythropoietin into bone marrow. Bone marrow will divide. That's a property of a bone marrow. You don't want anything else. Even if you look at the images, these images are called as blast forming units. Burst forming units or blast forming units. We'll read them when we come to hematology. What does it mean? But for me here to solve an MCQ, these two are more than enough. I'm giving erythropoietin, and the only way a bone marrow responds to erythropoietin, which is the growth factor, is growth, hyperplasia. It's not atrophy, it's not hypertrophy, it's not metaplasia. Right? It's a very, very simple thing. Saket, metaplasia will not happen because it's normal hyperplasia. I don't have any stress here. It will not change. It will be only normal hyperplasia. Fine. Okay. Next question. Again, read through it and then comment on it. I'll keep myself quiet for next few seconds. Okay. Let's read. It's a 75-year-old. So first clue for me here is age. It's an elderly person. Has Alzheimer's disease and dies due to heart failure. The brain is shown in the autopsy. So in an Alzheimer's individual, what will happen to the brain? That's all the question is. It's very simple, right? Again, never ever complicate things. You just need a clear mind to answer the question. That's all. Simple. If you're able to answer today, which means you have understood the topic. The same understanding should be present after 2 years, 3 years also. If you have that, you'll ace the exam, right? Now, I just want to talk about this brain. I want a little bit of your help to understand what happens in the image of an atrophied brain, right? I'll just zoom this here. What are these called as? There are something which are going inside, something which is coming outside, right? What are those called as? Normally, what do you call them? You call these depressions as gyre and sulci, right? I'm sure you must have heard about these terms. We have something called as gyre and sulci. Gyrus and sulcus, right? Or plural gyre and sulci. So what happens normally is, I shall come to it, just give me a second. What happens normally is a normal brain will have a beautiful Gyrene cell. Okay? You must have seen in your autopsies, in your posterior dissections. But if you look at this area, when you look at this area, maybe I'll use an yellow color. Look at this area. Can I say the Gyrene cell of this area, what I've circled, is more deeper? It's more deep, right? It's definitely more deep. That's where atrophy happens. Please remember, atrophied brain will have very prominent gyre and sulci because there is nothing inside. When the brain parenchyma is absent, obviously the invaginations will become more deeper, right? That's one of the clues. If you have an atrophied brain, remember this, an atrophy of brain will have more prominent gyre and sulci than normal. Okay? Because there's nothing inside, so it becomes more prominent. That's what, fine. That's what happens in a brain atrophy. Okay, this can be extrapolated to an MRI image also. Brain cell becomes prominent in MRI. I know it's an atrophy of a brain parenchyma. Fine. Okay, Harsh, coming to your question, anaplasia means there's a loss of differentiation. We'll read what is anaplasia when we come to cancers. Okay. One of the findings of neoplasia is anaplasia. Right? It's no differentiation. That's what means by anaplasia. Just for now, you remember that. That's enough. Okay. Next. We have not learned this, but let's see if you can just give a wild guess. This was the PYQ. Once it came, that's why I'm using this. 16-year-old radiological imaging, abdomen was found to have only one kidney. She was entirely unaware of the problem. Which of the following terms is the most descriptive of this finding? See, it's very simple. For me, in the imaging, the person is entirely unaware of the problem. Which of the following terms is most descriptive of the finding, right? She's having only one kidney. I'm talking about the kidney which is present, not the kidney which is absent. We'll leave the kidney. Perfect. The kidney which is present, this kidney has hypertrophy, right? It will become hypertrophied. Okay. I'm not talking about the kidney which is absent. For the kidney which is absent, I'm giving you two terms. Tell me which will be the best term. The kidney which is absent will be agenesis or atrophy. For the absent kidney, what will be the best term? Agenesis or atrophy? 16-year-old kid doesn't even know she has only one kidney. By birth, she has only one kidney. So it's agenesis or atrophy? It is perfect. It is agenesis. It's not atrophy, right? It's agenesis because embryologically it's not being formed. Atrophy is something which is normal, then it disappears. You had a thymus normally, then thymus underwent atrophy. You had a normal brain parenchyma, then it underwent atrophy. If the brain is not even developed, it's called as agenesis, right? So the kidney which is not there is having agenesis. The kidney which is remaining will undergo compensatory hypertrophy, right? Perfect. I hope you know the difference between the both agenesis as well as atrophy, right? Great. Right? The kidney which is present will have a compensatory hypertrophy. Kidney cannot undergo much of hyperplasia. It becomes bigger. It doesn't divide more as much as it can become bigger, right? Just in previous year question, remember them, right? Okay. We got just 3 MCQs for application. See, there are two very good source for MCQs. Whenever you're reading Robbins itself has a review book. Go and look at the review book. Every question there in the review book will be scenario based question. So you can easily apply. It's just Robbins review. Maybe if you're there in the PW's Telegram group, I'll share the PDF of that with you. Or you can Google it. It's there freely available in Google. A Robbins review book is a very good source for MCQs. Use them. Otherwise, use Lippincott. Lippincott's books also a very good source of scenario-based MCQs. It will not have one-liners, pure proper clinical scenario question, right? These are the best books in the market available for you to solve a good quality question, right? Questions are available everywhere. These two books are amazing. Please go and read it whenever you have time, fine? Okay, now let's come to the next part. We're going to talk about cell injury and necrosis. I'm just going to write the same thing what we read before. Sure, and I'll do it. Okay, data cell. We have the stress. That's where I said a stress can be nutritional, a stress can be mutation, a stress can be virus, bacterial, autoimmune, anything. Right? A cell had to adapt. If the adaptation fails, or if the stress is going to be persistent, if the adaptation fails, it will result in cell injury or cell damage. It will automatically result in cell injury. If the cell injury, initially the cell injury will be reversible. I had a damage, it will come back to normal. I can salvage it. But even then, the stress is more persistent or more severe stress, then it becomes irreversible cell injury. When it becomes irreversible cell injury, it results in cell death. This is what your second competency talks about: the reversible, irreversible cell injury and the cell death, which is by necrosis. Most of the pathological cell death are by necrosis only, it's not by apoptosis. Fine. Apoptosis physiological and some pathological also, right? Now let's look at the cell injury part. We look at what is reversible, we look at what is irreversible, we look at every morphological change in reversible, irreversible, with nothing to memorize. I'm just going to ask you leading questions. You're going to answer and we're going to learn together, right? I'm not going to teach, we're going to learn together. Fine. Okay. Let's take, I have a beautifully normal functioning cell. And the most common type of cell injury is going to be hypoxia or ischemia. Okay? I'm sure you guys know what is ischemia. Ischemia is loss of blood supply. A cell doesn't have blood supply. If a cell doesn't have blood supply, or let's say hypoxia, okay, this is what happening to a cell. Can it produce ATP? Yes or no? it cannot produce ATP, right? Simple. The cell is not having enough blood supply, not having enough oxygen. Can it function properly? It cannot function properly also. Simple, right? Then only my microscopy changes comes. Whenever I'm having a cell injury, there are few things which I want you to remember. Robbins has a timeline. The first thing which will be lost in any cell injuries, the cell's function. Simple thing. A cell cannot function when there's no inner oxygen or blood. The second thing which will alter is biochemical. You'll have a beautiful graph like this. Immediately after the damage, what happens is the cell function reduces. After then, my biochemical changes comes. After then, it will be written as ultrastructural. That's my electron microscopy. First is biochemical, next is electron microscopy, next is light microscopy. Later only to naked eye gross the changes happens, right? It's a sequence, right? The first is biochemical, will be gone. After that, the change comes in your ultrastructure. Wherever Robbins talks about ultrastructural changes, I'm talking about electron microscopy changes. I'll use the term EM for electron microscopy, right? After that only your light microscopy changes comes. Light microscopy, I will write MX for microscopy going forward, fine. Light microscopy is a simple microscopy, what you see in the lab. This is normal microscopy. Then the last one, I'll have gross changes. That is the timeline of changes. If you have 2 mark questions, something talking about timeline of change, the first timeline is cells function goes away, biochemical change, ultrastructural, light microscopy, electron gross change. This is the order, not only for my heart, for every cell in my body, same order only, right? Okay. Now we know the order. Now let's see what will happen when ATP is lost. What will happen when your ischemia is there, right? Simple things. Again, I'm going to say the same thing. My cell has less blood supply or less oxygen. Because of this, you guys only said that there'll be no ATP, or let's say less ATP. It will not stop completely, it will be reduced for sure. When I'm having less ATP, I'm sure in your physiology you must have heard about a pump, sodium potassium ATPase. One of the most horrible pump, right? After 10 years, you remember which comes in, which goes outside, you'll be still be confused. That's the beauty of the pump. It's an ATPase. Am I right in saying that it needs ATP for function? It does. So do you think that pump will work? Whenever ATP reduces, will sodium potassium ATPase work or it will not work? It will not work. Because of this, I'll have less functionality of sodium potassium ATPase. Because an ATP dependent pump, it's simple. Because the pump is not functioning properly, your cellular homeostasis will be affected. When the cell's homeostasis is affected, there's one tiny change happens. More amount of sodium comes inside, right? Perfect. Nokia has a good mnemonic, right? Hope it stays forever with you, Osama. Right? So sodium goes out, potassium comes in normally. Okay. So here, my sodium is not going to go out. Sodium is going to stay inside. Because of the sodium potassium ATPase function not working, what happens is there's a simple normal cell. I'm removing the nucleus. It's not working. So my sodium stays inside. My stored sodium is staying inside. Na is for sodium, right? It's staying inside forever. If sodium stays inside, what do you think will happen to the water? Will it come inside or will it go outside? I'm talking about water, not about potassium. It will come inside, right? This will cause influx of water. It's simple osmosis, right? A very simple osmosis. Water keeps on coming inside. If the water keeps on coming inside, can I say the cell will become bigger? Obviously, cell will become bigger, right? I'm drawing the nucleus here just for understanding. The reason for it becoming bigger is sodium was there, water came inside, right? So can I say anywhere in my body, when my cell is first affected, the sodium potassium ATPase will not work. So can I say the cell will swell? It will become bigger, right? It will become bigger. I'm just writing the light microscopic changes here. One of the earliest light microscopic change seen in cell injury is cellular swelling. This is uniform for every tissue in the body from head to foot. I give different terms in different places. That's all. In kidney, I call them vacuolar degeneration. Water looking clear like a vacuole. Some place I call it hydropic degeneration. Water again. Some place I call it spongy degeneration. Becomes soft. Water again. Ultimately, sodium potassium ATPase doesn't work. Sodium stays inside. Water comes inside. That's all right. So I have different terminologies here. We can call them in vacuolar degeneration. Vacuolar degeneration is for the renal damage, mostly used for renal damage. We call something called as in ballooning degeneration. It becomes big like a balloon. Ballooning degeneration is mostly useful for liver biopsies. In hepatitis, we'll use them when we go to hepatitis. When we read hepatitis, we'll definitely use them. We call something as spongiform degeneration. It becomes like a sponge. Spongiform is used in brain parenchyma. Ultimately, it's swollen cell. That's all. Wherever cell is damaged, it will become swollen only. That's my first light microscopic finding. I have one more superb light microscopic finding. We'll look at that. What do you think is the function of liver? Can anyone tell me the function of liver? Whatever comes to your mind. I'm sure you know that. See, you are fresh from physiology. You have to know the function of liver. And I'm confident that you will know the function of liver. Liver has two main functions. One is detoxification. The other is metabolism. Can I say that liver metabolizes fat? Is that statement right? LDL, VLDL, HDL, all the metabolism happens in liver. Right? When the liver is having a damage or an injury, can I say this metabolism will be affected and the fat will be stored inside? Because the first thing, what I said in any cell injuries, the cell's function will be reduced, right? It will reduce first, right? So when liver is having a damage, the fat metabolism stops and the fat starts storing inside. That's my second finding. Not every cell will have fatty change, but there are definitely few cells which will have fatty change. Fatty change is seen in liver and fatty change is seen in heart. So this is unique for few organ systems only, heart and my liver, fatty change. Rest, cellular swelling will be seen in every organ from my head to foot. So this happens because of my ATP reduction. Very simple finding, right? My light microscopy, I'm going to have these changes. But I need to learn about electron microscopy also, right? I have to learn about electron microscopy. We'll look at electron microscopy very soon, right? There are few more changes in light microscopy also, which we'll enumerate, but not in every organ, in few organ. Third, let's say the water keeps on coming inside, more and more and more water. What will happen to the cell finally? Will it burst? It will burst for sure, right? It will burst for sure, right? So what happens is, I'm having a cell like this, a normal cell, which became bigger. At some point in the cell membrane, it becomes weak and it starts to burst. So at that point, what happens initially? I'll have a tiny bleb. It not immediately burst. I'll have a weak area. It's like a balloon, right? There'll be a weak area, and this area will burst. This causes an cellular bleb formation. It's a controversial statement. Whether I see a cellular bleb only in light microscopy or I can see in only in electron microscopy, not sure. Robbins talks it uniformly in both ways, right? But I can see cell bleb formation if I'm lucky in light microscopy also, but definitely it will be seen in electron microscopy also. When I come to electron microscopy, I will write that as well, right? The fourth change. I have a cellular bleb formation. I'm going to write one unique cell. You're going to tell me the classical histology of the cell. In kidney, I have a very unique cell called as proximal convoluted tubule cell. The function of PCT is reabsorption. Everyone here knows that, right? It's a reabsorption function of PCT. Why PCT reabsorbs? Or in histology, it has a very unique structure which makes them reabsorb or which makes them increase the volume of the PCT. Can I say that PCT has a structure called as microvilli? It has microvilli. I'm sure you accept, right? In other words, when I take a proximal convoluted tubule cell, the normal proximal convoluted tubule cell, let's say that I'm having a very, very tiny microvilli like this. They are bristles, they are brush border, right? They are brush border, extremely close. The cell is going to swell It's going to become bigger and bigger and bigger. What do you think will happen to the microvilli? Will it be damaged? It's like a comb, like a normal comb, right? You're going to stretch the comb. All the bristles will be lost, right? So when the cell stretches, when my cell is going to stretch, automatically my microvilli also will be stretched, and you'll have loss of microvilli. Perfect. The brush border, the other one is other term for the brush border is microvilli, right? Loss of brush border or loss of microvilli. Both can be used simultaneously, right? Perfect. Okay. That's about. These are few changes. Again, I might not see microvilli loss in every cell. I'll see only in PCT. Like I see fatty change only in liver or heart. I'll not see them in every cell. Cell blood sometimes may be seen in light microscopy, sometimes may not be seen in light microscopy, right? All these, can I say, I'm having loss of microvilli, I'm having a swollen cell, I'm having fatty change or cellular swelling. Let's assume I'm able to identify the problem. I'm giving blood supply again. When I give blood supply again, the ATP will produced again. When the ATP is produced again, can I say all these changes will come back to normal? I have a good amount of ATP. Sodium potassium ATPase works properly. It will kick out all the water. Will the cell shrink again? It will. I'm having good amount of function. Hepatocytes will start functioning. When the cell shrinks, blebs will disappear. When the cell shrinks again, microvilli will regenerate. So in other words, can I call all the above reversible cell injuries finding, or it is irreversible cell injury finding? Everything what we read till now, perfect. They are features of, or in other words, we'll keep it complete. They are light microscopy features of reversible cell injury, right? Perfect. If you have a question talking about reversible cell injury, you can explain everything. You know points. See, without even knowing points, you must have written pages in anatomy, physiology, and biochemistry, right? I have been in that place. So with few points, you can definitely learn, write much better questions, right? These are all light microscopy changes of reversible cell injury. I have not got to the irreversible part. We'll go to the irreversible part. But like I said, I also want ultrastructure, or I also want electron microscopic changes of reversible cell injury. That is also required for me. Only when I know that, I'll be able to complete the entire question part, right? The electron microscopic changes are not used in real life. It's just for learning, it's just for understanding. That's all, fine. First, electron microscopy is nothing but extreme high magnification. You must have read them in physics in your 12th standard system, right? It's a very highly magnified microscope. That's all. Okay. Electron microscope will always have black colors, various shades of black, gray color, black color, a light white color. That's what electron microscopic images will be mostly, fine. So in electron microscopy, I can zoom in and I can even look at every organelle, not the cell. I can look at the mitochondria. I can look at the Golgi complex. I can look at the endoplasmic reticulum you separately. That's the power of electron microscopy, right? So when I say a cell swells, will the mitochondria also swell? Will the endoplasmic reticulum also swell? Will the Golgi complex also swell? It will. Because everything, water comes inside, it will go into every organelle, not just in the cell cytoplasm, right? In other words, in electron microscopy, you can see an swollen endoplasmic reticulum. I'll write ER for endoplasmic reticulum, which is an acceptable abbreviation. You have to know that, fine. Okay. So there are two types of endoplasmic reticulum. One is rough, one is smooth. What does rough have? Rough endoplasmic reticulum has something called as ribosomes, right? I prefer them. It is something called as ribosomes. When the endoplasmic reticulum swells, can I say in the rough endoplasmic reticulum, the ribosomes will be lost? It will be because it's my endoplasmic reticulum. I'm stuck on the top of it. When this swells, automatically it will be gone, right? Second finding for me is I'll have detachment of ribosomes. The ribosomes will be detached. Once the ribosomes are detached, the ribosomes will not be able to produce protein. Not be able to produce protein. Slowly I'm going to irreversibility, right? Okay, ribosomes are gone. Perfect. I know about that. Third thing, third and fourth are little bit more complicated. So understand, follow me very carefully. Fine. I'll go back here. In this area of bleb formation, right? In this area of bleb formation, am I right in saying that there will be cell membrane damage? Yes or no? I'm not saying rupture. Will there be damage? Only when there's even subtle damage, it can bulge, right? If it's normal, it will not bulge. There's subtle damage, that's why it bulges, right? So the areas of bleb formation, I will have cell membrane damage, which is important for you to understand. If that is true, what is every cell membrane made of? Any cell's membrane is made of phospholipid bilayer, right? So can I say in these areas, my phospholipid bilayer is destroyed? It is destroyed. It's damaged. When I have a damaged phospholipid bilayer, how it looks in microscopy, especially in electron microscopy, it looks like a whirl, right? So at the areas of the cell membrane damage, the areas of cell membrane damage, what I have is I'll have damaged phospholipids. I'll write PL for phospholipids, right? The phospholipid bilayer is damaged. This is seen at the areas of cellular bleb formation. And all the phospholipids which is getting damaged looks like this. Looks like an whirl, a black and white whirl. This we term them as myelin figure. I'll tell you why I call it myelin figure, and we'll definitely look at a myelin figure also very soon, right? The reason for calling it a myelin figure is, can I also say that myelin is also a phospholipid, sphingomyelin? Yes, that also is a phospholipid, right? So myelin is also a phospholipid, which means a normal myelin in electron microscopy looks the same. That's why here when I have damaged phospholipid seen, it also looks the same like a myelin. So I use the term myelin figure. That's all. It's just understanding about it. Fine. Here, great. The fourth finding is when my mitochondria swells, can mitochondria also have damage? Not destruction, damage for sure, right? So I might have few densities in mitochondria. We call them, it's actually amorphous, but it's always said as amorphous. It's amorphous. The reason why I'm splitting it is you'll know what it means. A is absent, morphous is morphology. Doesn't have any particular size or shape. It's amorphous or amorphous, right? Amorphous densities in mitochondria. I'll explain what does a density mean. See, anything in electron microscopy is based on the electron's density. If something is very black, which means it's more electron dense, you'll have black dots inside mitochondria. That's what I mean by amorphous densities inside mitochondria, right? Perfect. Now, like I said, these two are a bit unique for me. Now, what do you think will be the next step of irreversible injury? Can I say the cell membrane will rupture? Once it ruptures, it's irreversible, right? Obviously. So when the cell membrane ruptures, listen carefully and answer. Am I right in saying a ruptured cell membrane also will have damaged phospholipids? Will it have or it won't have? It will have, right? A ruptured or irreversibly damaged cell, can it have damaged mitochondria? It will have for sure. It will have for sure. In other words, can I say these two guys is possible in both reversible and irreversible cell injury? Yes? Do you get my point? Yes? So I'm just going to repeat it again. A normal cell has a bleb in reversible stage. So I have damage phospholipid, I have my myelin figure. And irreversible cell injury, which is ruptured, will also have damage phospholipid, will also have myelin figure. When I see more amount of myelin figures, more damage irreversible. Less myelin figures, less damage reversible. Tiny densities in mitochondria, reversible. Big densities in mitochondria, irreversible, right? That's why these two are more very important. The third and fourth finding are seen both in reversible and irreversible cell injury. Please be very careful about it. See, this is not required for a real life, but for an MCQ, it might be required. You might have a question. All of the following are seen in reversible cell injury except this guys can be seen in both. So be very careful about it, right? It can be seen in both reversible and irreversible cell injury. How do I differentiate this? When I have less quantity, less number of myelin figures, it's going to be considered reversible change. When I have more quantity or big densities, I call it irreversible change. Fine. So these are classical electron microscopic change, which I see. I can see cell block formation. I can see damaged phospholipids, amorphous densities, your swollen endoplasmic reticulum, and detached ribosome. All these are with reversible cell damage. I have not gone into irreversible at all. We'll go to it very soon. Right? Okay. This is an image from Robbins, right? I'm just going to take the image from Robbins. You guys are going to help me to understand the image. What is the structure? Always, it's going to be help from you. Only when you help, I'm going to talk about the next. What's happening here? What's a marked structure? If you want to zoom this, what is the structure? Can I call the nucleus? It's a nucleus, right? Perfect. So here, I'm having this is a kidney biopsy. Can I call this entire thing a tubule? It's a tubule, right? Round tubule. So there's nothing but a PCT, proximal convoluted tubule. What does this mean? If this is PCT, what is this? What is this? From the cytoplasm, there's something projecting inside. What is that? Okay, it's a normal proximal convoluted tubule, and this is your brush border. Can you appreciate the brush border? I'm having some tiny projections from the cytoplasm of the cell. That's your brush border. Clear? Perfect. So that's a normal PCT. A is normal. This is completely normal. Now look at this image. Maybe look at this place. This place. Are you seeing brush border? I'll zoom this a little bit. Maybe I'll zoom this a little bit. My brush border is kind of getting destroyed, right? It's not perfect. I'm not having a classical brush border here. It's there, but it's damaged. Here, look at this part. It's damaged for sure. It's not seen. Look at this part. It's not seen. It's damaged. Here, it's there. Here, it's damaged, right? Perfect. So can I say in the second image, the B image, I'm having loss of brush border or damage. It's not perfect. It's not perfect like the first image, right? So that's what happens in your reversible surgery. I'm having a loss of brush border, right? Perfect. The next image, the C image, we'll ignore it. We'll see it later on, fine. So this is what happens in a reversible surgery, a loss of microvilli or a loss of brush border, right? I hope you can appreciate the difference here. But still, can I see the nucleus here? Nucleus is intact, which means it's not dead cell. It's a reversibly injured cell. Perfect, right? Okay. What is the structure? That structure is called as a myelin figure, right? That's a beautiful myelin figure there. It's a world appearance called as a myelin figure. Perfect. Now let's try to extrapolate this myelin figure. See, learning basic science is not just to memorize things. You have to analyze them. You will have to extrapolate them so that when you come to abnormal pathological conditions, you should be able to apply and give a solution to it, right? Let's assume a cell dies by necrosis. Who do you think will come and eat? Who eats all the necrotic cell? Who eats all the necrotic cell? Can I say macrophage? Yes. I'm just going to extrapolate this myelin figure. You had myelin figure, and we know that myelin figure is seen in both reversible and irreversible cell injury, right? That statement is true. In a normal necrosis, the myelin figure will be eaten by macrophage. We look at the macrophage when they come very soon. The inflammatory cells come, they'll eat. Macrophage eats the myelin figure, right? Once they eat the myelin figure, they will digest them. They will digest them and they will reuse all the things. That's the purpose of macrophage. Any cell dies, eat them, have good protein, reuse them. Good lipid, reuse them, or send to liver for metabolism. That's what a normal macrophage does, right? Tell me, you are going to be very important here in this discussion. Tell me which organelle helps in the digestion of fat, or which organelle has lipases, which organelle inside my cell has enzymes capable of destroying other things. Can I call them lysosomes? Yes, perfect. So in other words, whatever I'm having here, the macrophage is eating and the digestion happens inside. The digestion happens with the help of lysosomes. Okay, clear till this? Any doubts? If you have any doubts, ask me. This is completely normal. Okay, now that's where pathology comes in and hits it beautifully. I am sure that you must have heard about lysosomal storage disorders. Have you heard about Tay-Sachs disease, Niemann-Pick's disease, lysosomal storage disorders in your biochemistry? You must have heard for sure. Right? There are something called as lysosomal storage disorder. So can I say in a lysosomal storage disorder, the enzymes of the lysosome are not normal, so they are not able to digest them properly. Is that statement right? It's correct, right? I'm not able to digest them properly, right? I have a lysosomal storage disorder where the digestion will be affected. The digestion will be less. Perfect. If digestion is less, can I say that these people's macrophage cannot digest myelin figure? Is that right? Osama von Geerk's is in glycogen storage disorder, right? I'm talking about the lysosomal group, the Tay-Sachs, Niemann-Pick, all of them, right? Okay. So if the digestion is impaired, can I say the macrophage in this patient will not be able to digest myelin figure? Yes. In other words, can I say the macrophage in this patient will accumulate myelin figures, will have more myelin figures, right? Because they can't digest, they'll have more myelin figures. So now let's make the beauty work. How does a myelin figure look? We know how the myelin figure looks. It looks like this. We also drew. It looks like a whirl of black and white, right? The person who first saw this macrophage of a lysosomal storage disorder, for him, he saw multiple things like this. He saw multiple inclusions like this inside the macrophage because the macrophage is not able to digest them. The guy, the guy didn't know about normal. That's the problem. If I know normal, no, I'd have told within a second it's myelin figure. He looked at it, black and white, black and white, black and white, and he named them. You must have heard about this for sure. He named them zebra bodies. And we read them as MCQ. Zebra bodies are seen in Tay-Sachs disease. The thing is, I'm not understanding. Zebra bodies are nothing but myelin figures. Because I'm having a problem in lysosome, it's not able to digest myelin figures. You can call it whatever you want. Black and white bodies, you can call it. You go and discover something in future, you name whatever you want. But it's simple. Everything will boil down to normal. If I know normal, I know abnormality. If I don't know normal, I have to memorize zebra bodies. That's all, right? Very simple thing. Clear? It's an extrapolation of a simple myelin figure. You will read them in medicine. You will have Fabry's disease having same inclusion. You will have all the lysosomal storage disorder which will have the same inclusion only. Maybe different appearance. Some might be oval, some might be big, some might be small. But ultimately, it's accumulation of myelin figure. Clear? Okay. Now we'll leave this here. We'll come back to the cell injury part. It's an extrapolation of a normal myelin figure. Now, I had a beautiful cell here which became a bleb. This is where we stopped it, right? The reversible part. Having a bleb, it is not yet ruptured. I'm sure you will accept that a normal cell membrane is semi-permeable. Normal cell membrane is definitely semi-permeable. So with the bleb formation here, can I say that this cell membrane will become more permeable? It will become more permeable, right? It definitely becomes more permeable. Especially to one ion, it becomes more permeable to calcium. So because of this bleb formation, calcium increases inside the cell. Normally, calcium is seen outside the cell. But because of this problem, what happens is there will be lots of calcium which contains inside the cell. The intracellular calcium concentration rises. Okay. I'll relate this to an MCQ. There's an old MCQ which was asked, what's the most common ion seen inside a cell in reversible cell injury? We learned reversible cell injury, you should be able to answer. The most common ion seen in irreversible cell injury is calcium. Common ion seen in reversible cell injury, sodium, potassium, ATPase didn't work properly. Who was accumulating inside? Sodium, right? In irreversible, I have calcium. In reversible, I have sodium, right? Perfect. Come back to this. The intracellular calcium increases. If you remember biochemistry, again going back to your basic science, I will take lots of your knowledge from basic science and I'll use here. Calcium, can I say, it's one of the important cofactors for enzymes. They activate lots of enzymes, lots of proteins they activate. One of the best examples is entire clotting cascade. Based on calcium, it activates them, right? Right, perfect. So calcium, intracellular calcium, will activate enzymes. There are three enzymes I'm worried about here. The first enzyme is phospholipase. Okay, the phospholipase is the first enzyme. Now here I had a beautiful bleb in the cell. Phospholipase gets activated. Can I say it will destroy more cell membrane and cause the rupture? Obviously, right? It will rupture the cell. So the cell is ruptured. Can it come back to normal? You're having a balloon, you blow a balloon, you rupture the balloon. Will it come back to normal at any point of time in your life? It will never come back to normal. So, in other words, can I say this is hallmark of cell injury or cell damage or necrosis? Because what we are going to learn here, the cell death is nothing but necrosis, right? So here, this is hallmark. The membrane damage here is the hallmark of cell death or necrotic type of cell death, because it will never ever come back to normal. That's if it's done, it's done. That's all. There's a point of no return. It can never come back to normal, right? It's a hallmark of necrosis or cell death. Next question. I'm going to extrapolate more with this point only. My cell membrane is ruptured. Am I right in saying that all the contents inside the cell will come outside? Yes or no? Will come outside, right? Any contents inside the cell will come outside, right? So because of the cell membrane rupture, my intracellular contents will exit outside. It's a very simple logic, right? Will leak outside or will exit outside. If this is true, if this is true, let's say a patient has heart attack. What do you think is the ideal way to diagnose? Do some blood test or ECG, or go and take a cardiac biopsy and say that, see, there is myocardial infarction, there is necrosis. Obviously, blood test and ECG is a very logical approach. I cannot go and poke the heart and take a biopsy when the heart is dying. That's when I use necrosis concepts. When heart undergoes necrosis, heart's membrane will rupture. When heart's membrane rupture, heart's content, the myocardial's content will come outside. The cardiac myocyte's content will come outside. That's why I use troponin T, troponin I, CKMB for diagnosis of myocardial infarction. You must read that in physiology itself, right? I use them, right? So the intracellular contents come outside. These contents are used for diagnosis. We will use it for diagnosis. It will definitely be used for diagnosis, not just heart. I just gave you an example of heart. In heart, I'm writing MI for myocardial infarction. You'll have your troponins, the trop T, trop I, everything coming outside. Troponins, your CKMB. CKMB is creatine kinase, the subtype, right? You must have definitely read about this in your biochemistry and physiology. That's nothing but necrosis, not just in heart. When my liver dies by necrosis, can I say AST, ALT will elevate? Okay. Most of the enzyme studies, what I do is based on cell death, is based on membrane rupture. That's all. It's always interlinked. See, this is what I want you to read in future. This is pathology. How I'm going to use it to the patient is what is more important for me. How I'm going to link it to diagnosis or management or prognosis. That's the only goal for us. Learning the microscope is not important. Where it's going to be useful. Everywhere necrosis is there in my body, it will release the contents outside. I can use it for diagnosis. Right? That's the first enzyme. The second enzyme which is going to get activated is your protease. Right? Second enzyme is your protease. The name says everything. Protease destroys protein. That's all. Entire cell is made of protein. The cytoskeletal protein, it will be destroyed, right? So it destroys protein. So this is important for me, right? Let's take a cell. Let's draw a cell. A normal cell's color is pink in color, right? It has a pink color. I'm having a pink color. Let's assume and there's a normal cell, sorry, with a pink color. Okay, normal pink color cell, fine. Here, the protease acts on the cell. The protease is going to act on the cell. It's going to destroy the protein, right? If a protein is destroyed, it becomes more pink or less pink. It's a very common thing which I like to link. It's a protein. The protein is destroyed. It becomes darker or lighter. It's a normal cell and every protein is pink in color, right? a destroyed protein will become darker. That's very, very important. With this, I will use two examples. One real life example. Omelette is destroyed egg protein, which becomes opaque, becomes darker. In your biochemistry, have you heard about the urine? You fill the urine three-fourths of the tube. You heat the tube and the tip of the test tube. It forms a coagulum. It becomes darker. Anywhere protein is destroyed, the protein becomes darker. It becomes more darker. It doesn't become lighter. Right? It becomes darker. That's where Robbins used the term any cell death or whenever I have protein destruction, it becomes more intensely eosinophilic. It becomes intensely eosinophilic. Remember, this is a question. Why is a question is when I asked you whether it becomes lighter or darker, everyone, most of you, or almost everyone invariably said it becomes lighter because in my brain it's always there. Once it is destroyed, it becomes light. But protein, when it's destroyed, it precipitates. Precipitates or coagulum is always darker, right? You guys, you need not be sorry at all. It's completely fine, right? I have made much more worse mistakes than you, right? Don't worry about mistakes. It's fine. You guys will not forget when you make a mistake, right? It becomes intensely eosinophilic. There's an MCQ. You might miss it because it's not the routine way of thinking, right? Got it? Next. Third one. Third guy for me here is nuclease. Okay? I have phospholipase, I have protease, I have nuclease. These are three enzymes which will be activated during the irreversible cell death. Fine. Let's take again. I'm going to use the normal things what you already know. Which chromatin I call it as functional chromatin, euchromatin or heterochromatin. I have two types of chromatin. You must have read in biochemistry for sure. Which is functional, U or hetero? U is functional, right? Euchromatin is functional chromatin. Heterochromatin is non-functional. So let's say I'm having a beautiful nucleus. I'm having a euchromatin, which is a functional chromatin, right? Any chromatin, when it has to function, it will has to open up. It will open, then my mRNA will be formed, then it produces protein. When it's closed, it becomes non-functional. When it opens, it becomes functional, right? So any chromatin which is functional, which is open, will be lighter in color. So any functioning nucleus will be a little bit of light blue in color. Okay, we'll have a light blue tinge. The first thing what's going to do is my nucleus is going to make it non-functional. I'm having a nucleus, destroy the nucleus. It will not become functional. So what happens is it becomes smaller and a darker nuclei, right? This smaller and darker nuclei, I use the term pycnotic nuclei. It's a smaller nuclei and a dark nuclei. It's small, dark. I use the term pycnotic. That's a first change what I see in cell injury in nucleus. It's pycnotic. It's become small and condensed. More and more and more enzyme acts on it. What do you think will happen to the nucleus? Will it be staying like that or it will break down and disappear? It will break down and disappear for sure, right? The first change is forming pycnosis. If this continues, it will continue for sure. What happens is my nucleus breaks. It breaks into fragments. The technical term for nucleus is karyo. You must have heard about karyotyping, typing my nucleus, right? That's karyotyping. I use term karyorhexis. Rhexis means to break. Karyo is for nucleus, right? It will be broken, karyorhexis. The final one here is, it'll be completely gone. Everything will be disappearing. I call that karyolysis. It's completely gone, karyolysis, right? There are three nuclear changes. You must have known this for sure. Pycnotic, karyolytic, karyolytic. What's the color of nucleus? I want everyone here to comment. Even if you make a mistake, doesn't matter. What is the color of nucleus? Pink or blue? Blue in color, right? So in necrosis or in irreversible cell death, I'm having pycnosis, karyorhexis, karyolysis. Once the nucleus is lysed and disappears, it disappears completely. Will there be blue color in a necrotic tissue or not? Will you have blue color or not? You will not have blue color. So can I say Every irreversible cell death due to necrosis will be pink in color and no blue color because I'm having karyolexis and karyolysis. Is that statement right? Absolutely right, right? That's what happens, right? I want you to remember this. I will show pycnotic nucleus also. I will show lysed nucleus also very soon, right? Look at this image. I'm having two cells here. It's a pap smear here. I'll look at both the cells here. I'm going to mark two nuclei here. We'll name them as 1 and we'll name them as 2. Can I say the first blue color is a bit bigger and lighter? That's your euchromatin. The second one, what I marked here, can I say it's dark and smaller? Yes, that's pycnotic, right? That's a pycnotic nuclei. It's extremely condensed and dark and pycnotic nuclei. This is a lighter nuclei, completely light, right? Pycnotic nuclei, and I have a lighter nuclei, right? Perfect. Here, done. So you know about pycnosis. Once you know about pycnosis, let's look at the rest. Everything we can learn about it, right? We saw a proximal convoluted tubule image, right? Hey, look at this. You said that this is where I have loss of microvilli. Look at the third image. This is also my proximal convoluted tubule only. Are you seeing any nucleus in this image? Are you seeing nucleus? Consider the entire tubule only. Are you seeing nucleus? No, right? You're not seeing nucleus. This is necrotic. In other words, if you don't see nucleus, only pink color, think of necrosis. Because nucleus is gone, it's karyolytic, right? So I am normal, I have reversible cell injury, maybe this is an irreversible cell injury. Everything is there in sequence, right? Perfect. So we know what happens in an irreversible cell injury. That's my calcium enters, phospholipase activates, protease activates, nucleus activates, right? So now I know what happens. At the end of it, it's not yet complete. My cell, which is beautiful like this, due to all the problem, it got just fizzled out. It was broken, my cell membrane was gone, all the contents came outside. I had very dark destruction of the protein. It was everything was gone, everything was destroyed, everything was there. So now this cell is lysed. This will release few important molecules. We call them as DAMPs. It's important. It was added in the 10th edition of Robbins. Before that, we were not having more emphasis on DAMPs in the first chapter, right? So DAMPs here means, okay, DAMPs stand for damage associated molecular patterns. Okay? It's damage associated molecular patterns. What do I mean by this is a normal protein has a different shape and a size. A destroyed protein is a DAMP. It's not normal, it's not protein. A destroyed phospholipid is a DAMP. A destroyed nuclear debris is a DAMP. So whenever I have DAMPs coming inside, these guys will attract inflammation. They will attract the inflammatory cells. So this will definitely result in all the inflammation associated with necrosis. Necrosis has inflammation, right? That's one of the classical difference between necrosis and apoptosis. The DAMPs is going to attract inflammatory cell. It brings in neutrophils. Slowly neutrophils will be replaced by macrophages. And the macrophages roles and the neutrophil role is nothing to eat the all the dead particle. Eat, clear the area, right? I'm just going to ask you a very random question, not related to your MCQ or your university exam, just to think. Comment below which you think is better, necrosis or apoptosis, which is better? Which you think is better, necrosis or apoptosis? But a few of you will say apoptosis is better, right? That's a traditional way of thinking. Yeah, I'm just pushing you out of the box. I'm just making you a little bit think outside the box so that when you have a problem statement down the road, you will start thinking. If I can make at least 1% of the people listening here think, my job is done. Necrosis is better. Apoptosis is not better. Because anywhere I have necrosis, I have inflammatory cells. When I have inflammatory cells, am I right in saying that there will definitely be pain? Yes, you will have pain. You'll definitely have pain here, right? When there's pain, will the patient come to me? Patient will definitely come to me. The patient comes to me, I can intervene, I can diagnose, I can treat. But apoptosis, no inflammation. Am I right in saying that in apoptosis, there'll be no pain? It's extremely silent. Alzheimer's is apoptosis. I know that brain is dying only when you start forgetting things. I intervene at a later stage. Tumor is apoptosis. Tumor is not painful. If it was painful, it comes at the very early onset, right? Necrosis might cause sound, might cause inflammation, but it's very, very good for me because I can intervene as a doctor and I can manage the patient. Apoptosis is silent. Not everyone who is silent is good, right? Apoptosis is not good. Pathological apoptosis is not good. Physiological apoptosis is definitely good. The pathological apoptosis is definitely bad compared to necrosis, right? That's the difference between necrosis and apoptosis. We'll tabulate them when you go to apoptosis for sure, right? Okay. So now we know a little bit about your necrosis, the entire outline of necrosis. Next part for me of this lecture is the types of necrosis. I have 5 different types of necrosis. I'm sure you guys know. Can anyone comment on the type of necrosis? I'm sure you know all the types of necrosis. Just I want to hear from you. Fat coagulative, gaseous, liquefactive, fibrinoid, fat. Just 5 different types of necrosis. If you know 5 different types of necrosis and if you're confident in diagnosing the 5 different types of necrosis, you can diagnose all the necrotic lesion from head to foot because only 5 types of necrosis happens from head to foot. That's how important my general pathology is, right? We'll compare two guys, coagulative necrosis. We'll compare the coagulative necrosis from liquefactive necrosis, right? We'll just try to compare these two guys, coagulative and liquefactive. I'm sure you must have heard about coagulative and liquefactive. I'm also sure you must definitely know which is more common, right? I'm 100% sure that you'll know which is more common. Which is more common amongst these? Coagulative or liquefactive? Perfect. Which is more common amongst these? Coagulative is more common amongst these, right? Definitely is the most common type of necrosis. You must also read for sure coagulative necrosis is seen in all solid organ infarct except, sorry, coagulative necrosis, it's seen in all solid organ infarct except which infarct? All solid organ infarct except one infarct where I see liquefactive necrosis, which is brain infarct. You must have known for sure, right? You must have definitely known this for sure. Brain infarct has liquefactive necrosis. Perfect. Okay. Again, you're very, very young in your career. I want you to ask queries whenever a fact is thrown to you. Don't receive a fact. If someone is throwing you a fact, if someone is giving you a mnemonic, if someone is asking you to memorize, they are not letting you grow. Why brain undergoes liquefactive necrosis should be the question. It's an infarct, right? Infarct means only one should be there. Why brain is alone unique? You should have asked it when the teacher teaches you. If you look at textbooks, textbook will say not clearly understood. Learn more because it will be there. Answer will be there, right? I'll tell you the easiest answer. All of you must have touched brain, right? Soft or firm or hard. In your dissection, you must have touched brain for sure. Soft or firm or hard? Brain is extremely soft. It's very, very soft. One more organ or one more part of the body which is very, very soft is touch your tummy. You're young, right? So tummy might not be there. You grow old, become 30 plus, tummy will automatically come. It's like a baggage, right? Touch your tummy. Tummy is also very soft. In other words, brain is primarily made of fat. It's a fat-rich organ. Fact. The fat-rich organ. And it's amazing. That's why omega-3 fatty acids help in the brain's development because it helps in the development of the fatty parenchyma or the myelin there, right? Perfect. So now my mechanism of coagulative necrosis, the main mechanism by which coagulative necrosis happens is protein degradation. The main mechanism of coagulative necrosis is protein degradation. It destroys protein, destroys the cell. Now, can I use protein degradation to destroy brain, which is primarily made of fat? I cannot. I cannot definitely do that, right? For brain which is full of fat, I need lipase because lipase destroyed it, right? So here my mechanism of destruction is not protein degradation, it is enzyme activation. What enzyme? Lysosomal enzyme activation. Here all the lysosomal enzyme gets activated because I need lipase, and my body know and you know that lysosome have lipase. So this lysosome will release lipase which will destroy brain. But here it's a protein degradation. So my mechanism differs in two types of infarct. That's why I'm having a different type of necrosis there. It's not a fact, there's a reason. Why I want you to know the reason is, do you think any sane doctor will take biopsy for a stroke patient of brain? A patient comes with stroke. We know it's an infarct of the brain. Do you think they'll take biopsy? No. I will never ever look at liquefactor necrosis or brain infarct in real life. If it's not useful in real life, it's a useless term. So brain infarct is not what I want you to remember. But I want you to remember other conditions where I can have lysosomal activation. That's what it's important for me, right? The other conditions like, I'm right in saying that pancreas has lipases. Is that statement right? It's right. You must have read in your first year also. In pancreatitis, there'll be lots of activation of the enzymes. Lots of activation of the enzyme, right? So in pancreatitis, an acute pancreatitis, can I have lysosomal activation or lipase activation? It results in liquefactor necrosis, right? So second thing for me here is an acute pancreatitis. Because here also I have lipase activation or the lysosomal enzyme activation. An acute pancreatitis, yes, I have liquefactor necrosis. Not just that. You must have read about granulocytes, agranulocytes, WBCs in your first year. All the granulocytes, they have granules which are nothing but lysosomal enzymes only, right? So when you have a disease which has lots and lots of neutrophils, accumulation of neutrophils in plenty, is there a possibility that disease can have all the granule or the lysosomal granule being activated? Can it get activated? Definitely possible, right? Definitely possible it can get activated. If it gets activated, tell me a condition where you'll have lots and lots and lots of WBCs, especially neutrophils. A space, my hand, I have a swelling. Inside the swelling, it's only neutrophils. The other name of neutrophils is pus cells. Can I call them an abscess? Call them an abscess. That is important for me. In an abscess cavity, I will have liquefactor necrosis because in abscess cavity, I have lots and lots and lots and lots of pus cells. Pus is nothing but neutrophils. More and more neutrophils, more and more activation, more destruction, liquefactor necrosis. If this is true, have you heard something called as gangrene? You must have heard something called as gangrene. You must have seen your specimens of gangrene also. The definition of gangrene is, it's an gross terminology. It's not microscopic. Gross terminology for an infarcted tissue or an organ with change in discoloration is called as gangrene. As a definition of gangrene. There are two types of gangrene: wet gangrene, dry gangrene. In wet gangrene, I'll have more pus. So, wet gangrene is liquefactive necrosis or coagulative necrosis? A very simple question. Perfect, simple, right? So, wet gangrene, though it is a solid organ, in wet gangrene there's more and more and more inflammation, so it results in liquefactive necrosis. In wet gangrene, I'll have liquefactive necrosis. In dry gangrene, which is a simple solid organ infarct, no superadded infarction, you'll have coagulative necrosis. Because in wet gangrene, what happens is you'll have superadded infarction. The superadded infarction will result in inflammation, will result in lots of pus cells, will result in liquefactive necrosis. Right? That's more important. It's not the brain infarct which I'm worried about. It's the abscess cavity. It's a wet gangrene where I'll see liquefactive necrosis. That's what I'm worried about, right? So we know about dry gangrene, we know about wet gangrene. You know a subtle difference between your coagulative and liquefactive necrosis. Just one point alone is left. We'll look at that point very soon. You are sitting in a room, right? I have two types of necrosis. One is going to destroy protein, one is going to destroy the lipid parenchyma. Coagulative necrosis is not very forceful damage. It's like a subtle damage. Liquefactor on the other hand is very forceful damage. Let's say that someone comes inside your room, throws everything, breaks the chair, breaks the table, everything goes away. That's what coagulative does. Destroys all the proteins inside. But the outer wall will be intact, right? Even if you destroy and everything in your home, in your room, still the wall will be there. Can I say the architecture will still be maintained if there's a less force of destruction? Yes. Let's assume in your same room, Hulk comes, goes and destroys everything. Hulk is like liquefactor necrosis, more force of destruction. Will even destroy the wall because it's more force. So when there's liquefactor necrosis, the architecture is lost. In coagulative necrosis, architecture is maintained. I will show you images to explain that. Just remember this for now. Here, my architecture is maintained. Here, the architecture is lost. It's completely lost in one, it's completely maintained in one, right? I'll tell you what do I mean by architecture maintained because I'm sure you'll have doubts. Mr. Hard doubt this guy only said quite a few minutes back that cell membrane will be damaged. Then what he's talking about architecture. If you have a doubt, ask me, no? I'm not going to scold you for your doubts. Even if you ask me is necrosis cell death or if necrosis is normal, I'll answer that also, right? Architecture is maintained, architecture is lost here, right? Now let's look at an image. This is also an image from Robbins. This is a kidney biopsy. This is your glomerulus. Okay? We'll ignore the glomerulus for now. That's not needed for me for now. I will draw a line here. Right? Whatever is on this side of the line, right? This part of the line, okay? This side of the line. Can I say this entire area you are seeing blue color? You're seeing blue color? So can I say it's a live cell? Yes or no? Just comment this part wherever it's been written N. Can you see the nucleus? And can I call it a live cell? It is live, right? Perfect. On the other hand, this side, is there nucleus? Is there blue color or it's more pink color? This part, it's more pink or blue? It's more pink. So can I say this part here is more of necrosis and the other part is more of live? It is, right? So this part is more necrotic, this part is more live, just with pink and blue. That is enough for me for life, right? Now, I told you it's a kidney biopsy, right? And I told you, and you guys accepted that this part is dead tissue. But even if it is dead, can I say, can you say, what structure is this? It's a kidney biopsy. Tell me what structure is this? Is it glomerulus or tubules? It's a dead tissue. Even if it is dead, the tubule architecture is maintained, right? I'll zoom out a little bit. Can you see the tubule? They're dead, but still the architecture is maintained. Even if it is dead, the architecture is there. That's what I call it as architecture being maintained, and that is coagulative necrosis, right? When the architecture is maintained, even if it's dead, I can say it's a kidney. But in brain, you cannot say it's a brain. It will be only pink in color. There will be no architecture at all, completely lost, right? Perfect. So I'm sure you'll be able to diagnose it's a coagulative necrosis. There's one fancy term, like Osama said, whenever the architecture is maintained, look at these tubules. These tubules don't have life, but still it has a shape. Because of this, it was given a term ghost cell. It has a shape but no life. Scooby-Doo, Casper, right? It has a shape but no life inside. So the architecture being present, they also call them ghost cells being present. There's a very stupid analogy, but yeah, people ask MCQs in that. And here, when the architecture is lost, the ghost cells are absent. Okay, but the only thing is, I'm want you to appreciate the architecture being maintained here. Fine. Now let me zoom this up. When I asked you and when I told you it's only pink or only pink and blue, you said only pink, right? Now you're going to tell me, so what is this color? Ask me questions, no? That's how you're going to improve. What is this color? Pink or blue? Blue in color, right? Don't accept whatever I say. Answer me back, question me back. I don't mind at all. But please question back. Only when you question back, you will know the answers, you will improve. Right? There are blue colors here. There's blue color here. There's blue color here, right? So when you look at all these blue colors in between the things, all the blue colors are seen in between the tubules. It's not seen in the tubule. It is seen between the tubule. Can I say necrosis will have inflammation? It will have inflammation. So these are all inflammatory cells, the neutrophils, the macrophages, which is there present. So when you see blue color in between the tubules, that is not nucleus of the tubules. It's a nucleus of the inflammatory cells which just come inside. Right? Perfect. Very good, Sarabpreet Singh. Right? That's neutrophils. Right? So remember, if you see predominantly pink color, here and the scattered blue color, which means inflammation has come inside, but still it's a necrotic tissue only, right? Perfect, great. Okay. So now we're done with your coagulative and liquefactive. The third guy is caseous. What does caseous mean? Everyone here will know the answer. What does caseous mean? Caseous means cheese-like, right? Caseous is equal to cheese-like. Cheese-like means white in color. Yes, right? Cheese means white. It's white in color. So listen carefully and answer this question. It's caseous, cheese-like, and white color necrosis. So white color will be seen in naked eye or in microscopy. In microscopy, the color of necrosis is pink. Just now we saw, right? Just now we saw it's pink in color, right? Perfect. So it's white in color. So it's only a gross terminology. Even in Robbins and in multiple textbooks, you will read in microscopy caseating necrosis. In microscopy, I don't have caseous necrosis. It's a gross term because it's cheese-like. Cheese will be seen only in gross. White color will be seen only in gross. Microscopy is always pink. In microscopy, it's bit of an granular appearance. It has a little bit of a granular appearance. It's like coagulative necrosis only. It's a bit granular. That's what I can differentiate them. But I need a microscope. In a photo, I cannot differentiate them. It's a bit more granular than a normal necrosis, right? Whenever you see caseous necrosis, the only etiology which I want you to remember is tuberculosis. It's TB, only TB. Unless proven otherwise, TB. You are in my country or you are in any part of the world, the first diagnosis is TB only. If TB is not there in the option, look for others. I have few conditions called as histoplasmosis. We will read them. You know what is histoplasma when you go to microbiology. It's an parasite and fungal organisms. You'll read in the end of microbiology, right? And we also have one more guy called as coccidiomycosis. All these are mycosis, fungal organisms. You'll read them. Infections, you'll read them later in microbiology, right? First and the foremost thing, TB. Unless proven otherwise, TB, that's all. It's actually caseous necrosis. This part, it's a bit granular. I'm not sure if you're able to appreciate the difference. It's the reason why I'll come to it, Manoj. I was just about to come to it. Why granular, right? Good question. Ask questions, right? Reason why it's granular in microscopy is it's caseous, it's cheese-like. What makes them having caseous necrosis is tuberculosis membrane. It has lots of lipid component. The lipid component of the bacteria, the mycobacteria, is seen here. I'll just zoom this part. Can I say you see pink color, but also you see some clear area in between, tiny bubble like areas everywhere. Look at this. You see tiny bubble like areas. So the fat admixed. That's the reason it looks granular, because the admixed fat, because of the lipid component in the TB, the bacilli, it gives a different thing, right? It gives a different appearance. That's all, right? That's why it's a bit granular, right? Good question. Keep asking more questions like this, right? Okay. So we know why it's caseous necrosis granular, and we know the difference between a normal necrosis and a caseous necrosis, right? The next guy is fibrinoid. It's fibrinoid, but I am splitting it because I want you to know what does oid mean. This you have to remember till you practice medicine. Oid means like. Never ever forget this. Fibrinoid means fibrin-like. Lymphoid means lymphocyte-like. Amyloid means amylin-like. Oid means like. So what does thyroid mean? Thyre-like, right? What is thyre? Thyre in Greek and Latin or whatever language it is means butterfly. It's a butterfly-like gland, so I call it thyroid. Colloid, collagen-like. Oid means like, that's all, right? So fibrinoid means it's fibrin-like necrosis, right? That's all. It's simple thing. If you remember this, that's enough for me forever. Fibrin is seen in only one place, blood clot. Fibrin, fibrinogen, fibrin or fibrin, however you pronounce it, it's fine. Right? So whenever a blood vessel is injured, I'll have a blood clot. The blood clot will have the fibrin strands, right? In other words, fibrinoid necrosis is equivalent to vessel wall necrosis. That's all. It's a vessel wall necrosis, very as simple as that. So any disease, if you have the vessel being damaged, it will have necrosis, something called as fibrinoid necrosis, fibrin-like necrosis, right? Tell me any disease which you know where vessels can be damaged. Anything which comes to your mind. I'm sure you must have randomly read few diseases in your clinical anatomy, physiology, and biochemistry. Any disease which comes to your mind which will damage vessel. Can I say vasculitis? That's the simplest one, right? Every damn vasculitis will have fibrinoid necrosis. Be it your giant cell vasculitis or your microscopic polyangiitis, any vasculitis will have fibrinoid necrosis. That's one. SLE, systemic lupus erythematosus. It's actually a vasculitis, right? In other words, type 3 hypersensitive reaction. We'll read hypersensitive reaction when we come to immunology. So type 3 hypersensitive reaction will have fibrinoid necrosis. Atherosclerosis will have fibrinoid necrosis. Perfect. Anything regarding vessel will have fibrinoid necrosis, right? You must have heard about rheumatic heart disease, or you will learn in your streptococcus when you come to your microbiology. You must have learned. In rheumatic heart disease, we have a microscopic finding in the myocardium. Heart is the biggest vessel, right? We have a structure called as Aschoff bodies. We will learn these Aschoff bodies when we come to your cardiovascular chapter, right? RHD is rheumatic heart disease. I'll expand it because you're very young. Okay. Rheumatic heart disease is different from rheumatoid arthritis. Okay. You must have heard about rheumatic heart disease in your streptococcus. You'll have Aschoff body. Heart is the biggest vessel that also will have it. He also will have giant cell will have atherosclerosis will have anything will have. Have something called as malignant hypertension. Okay. So malignant hypertension means you might have heard them in physiology also. When my blood pressure is like 190, 200 millimeters of mercury, I call them malignant hypertension. So much high blood pressure. Can the vessel rupture? It can rupture, right? That also vessel wall rupture, vasculitis, hypersensitivity, Aschoff body. Anywhere you have fibrinoid, your vessel wall damage, you will have fibrinoid necrosis. That's all, right? That's a simple explanation. Fibrinoid necrosis. What structure is this? What structure is this? What do you have here? Whenever you have a structure, don't try to diagnose with complicated stuff. Simple stuff. What's the color here? What's the color here? The color is red in color, right? It's a red color. Anything red in color in my body is blood. So this entire structure is a blood vessel. Don't go for intima media adventitia. It's very, very difficult to understand by intima media adventitia, right? It's a blood vessel. I have a red color, which is blood. So the entire guy is blood vessel. So in this blood vessel, can I say there's an area where I see only pink color, no blue color? Yes, I'm just drawing that area. And something is only pink in color. In a blood vessel, I'm having a necrotic area which is pink color. That's how your fibrinoid necrosis looks like. Okay. That's your fibrinoid necrosis, right? You have blood vessel and a fibrinoid necrosis. So we know about fibrinoid, we know about your ischius, we know about liquefactor, we know about coagulator. Just one guy left. This fat necrosis. See, I want to divide fat necrosis into two broad terminologies. One is enzymatic fat necrosis The other one is traumatic fat necrosis. Traumatic is very simple. Any organ rich in fat, breast parenchyma, gluteal area, your deltoid, abdomen, repeated trauma or any amount of trauma will destroy fat. That's all. This is seen in any fat rich structure. Okay, it's seen in fat rich structure. Any fat rich structure. Let's say that a person keep on getting gluteal injections, just IM injections again and again. Fat will be destroyed. When you keep on giving insulin in the same place again and again, you have a side effect called as lipodystrophy, atrophy of the fat. Lipodystrophy, abnormal atrophy of the fat due to insulin injection, is due to fat necrosis. Any fat rich structure, you have trauma, you'll have necrosis, be it breast parenchyma, be it abdomen area, be it your thigh, anywhere. I'll have trauma, I have fat necrosis. That's the first thing. And the easiest one. Enzymatic, we learn a little bit carefully. So for enzymatic fat necrosis, let's take a disease called as an acute pancreatitis. So I want you to first answer a question. What type of necrosis do we see in acute pancreatitis? Caseous, coagulative, liquefactive, fibrinoid. What type of necrosis? In acute pancreatitis, the lipases will come outside. We saw them, right? It'll have, perfect, it'll have liquefactive necrosis, right? In acute pancreatitis, I'm going to have liquefactive necrosis. When you have liquefactive necrosis in acute pancreatitis, that will automatically, am I right in saying that this, due to liquefactive necrosis, it's enzyme activation. So can I say the lipases will leak outside? It will definitely leak outside, right? It will destroy the pancreas and definitely there's a possibility it will come outside. Because one of the tests, what I do in acute pancreatitis, lipase assay. So lipase will definitely come outside. Sorry. Lipase will definitely come outside. When the lipase leaks outside, you must have seen the pancreas for sure. In your anatomy, you must have read about the pancreas, right? That if you have a pancreas here, okay, let's say you have a pancreas here, surrounding the pancreas, you have fat. I call them peripancreatic fat, right? This is my pancreas. Surrounding the pancreas, I have peripancreatic fat. Can I also say pancreas is covered by omentum? And what is omentum made of? The cover. Omentum is made of again same fat. Pancreas will be covered by omentum for sure, right? It will be covered by this like a drape. It will be covered. The omentum is also made of fat. Now, when this lipase guys, when they leak outside, can it go and destroy the peripancreatic fat and can it go and destroy omentum, which is primarily made of fat? It can. So tell me, what type of necrosis happens in these two conditions? These two conditions allow enzymatic fat necrosis. Why this is important is an MCQ is where you get problems. So if an MCQ is asking about acute pancreatitis, tell it's liquefactive necrosis. The same MCQ says that there's an episode of pancreatitis and then in omentum I am seeing what type of necrosis? Fat necrosis. Or in peripancreatic fat, what type of necrosis? Fat necrosis. Only in the pancreas liquefactive, everywhere outside the pancreas, it's due to lipase induced fat necrosis, right? I hope you'll be able to differentiate them, liquefactive and your fat necrosis, fine? Clear? So what Robbins must have told is, Robbins must have just given you a new concept in this omentum. What it must have written is, in omentum, there's fat necrosis, and the fat necrosis omentum, along with the most common ion in any necrosis. What's the most common ion in any necrosis? Calcium. It forms calcific deposits. It forms calcification, or it will be called as saponification, right? I'll use the same term so you feel a little bit happy. Okay? Saponification is a very useless term or a soap formation. It nothing but means calcification. The fat necrosis with the calcium, which is the most common ion in any necrosis, will result in calcification. This is what Roberts must have told, right? Whenever you have a fact thrown to you again, read it carefully. and ask questions again. Am I right in saying that calcification will be seen in any necrosis or only fat necrosis? Just answer that alone. Because can I say calcification is something which is seen in uh, coagulative necrosis also? Most common ion is calcium. Liquefactor also same. Ksh is also same. Yes. I'm explaining it here. Doesn't mean that calcification will be seen only in fat necrosis. It can be seen in any damn necrosis. Whenever there's a tissue injury by necrosis, the most common ion in necrotic tissue or irreversible cell death is calcium. On a long term, it will cause calcification. Remember that, right? It's not just here, anywhere it will cause calcification. Okay. So, fat necrosis of two types, traumatic and enzymatic. What's the normal color of fat? The normal color of fat is a thumb rule, clear, right? This is a Robbins image. This is your normal momentum, and these are the calcific deposits of momentum, right? The fat necrosis, the calcification or saponification. Right? There's an image, normal fat, normal fat, normal fat, because normal fat is clear. The area between this fat, normal fat, where you have the little bit of pinkness, this area is necrotic area. Even in fat necrosis, the necrotic area becomes pink in color. It's always pink in color. There's a pink necrotic area. Okay? That's how it looks, a pink necrotic area and a normal fat, right? And this is not there in Robbins, but just for you to understand that even fat, when it undergoes necrosis, it will become pink in color. That's how everywhere, any body, throughout the body, if it undergoes necrosis, it will become pink in color, right? Okay? So that's about fat necrosis. So we know about all the different types of necrosis. We know about reversible cell injury, irreversible cell injury, the morphological changes, and also the atrophy. So whatever competencies we want to discuss today, we're done. Maybe two questions. We learned necrosis. Let's apply it today itself, right? See, let's just comment on the answer. Whoever is online here now, I want you guys to comment on the answer. Doesn't matter if you're right or wrong. That's secondary. Just comment on the answer, whatever comes to your mind. 50-year-old experienced an episode of chest pain for the past 6 hours. A representative section is given here of the myocardium. I'll just highlight whatever important things required for you. Myocardium. There's no hemorrhage, no inflammation. Which of the following is the most likely cause here? 50-year-old, chest pain is one clue, and the myocardial biopsy. I'll give you one more clue. Look at this area. What's the color? Pink or blue? Predominantly pink color. With a chest pain and the person died and predominantly pink color in my biopsy. Can I say it's a necrotic tissue? Is that statement right? It's a necrotic tissue, right? I'm sure most of you will agree it's a necrotic tissue. In other words, can I call this disease as myocardial infarction? Heart attack? Yes. So now look at the options. Which of the four options can cause an heart attack? Will protein deficit cause an heart attack? No. Trauma? No. Autoimmunity? No. Can an thrombus is nothing but occlusion of the blood vessel, can cause a heart attack? It can, right? So I'm having necrotic area. So my diagnosis here is myocardial infarction. And the only etiology amongst the four options which can cause heart attack is your arterial thrombus. It's a bit difficult question. You'll have to link a lot, but I want you to get used to interlinking facts very early in your career so that you'll grow beautifully well, right? So key points here is chest pain. I just want someone at least to ask that question. Very good question, Harsh. I'll answer the question. Chest pain, ventricular myocardium, arterial thrombus, right? And I have only necrotic color, right? Perfect. Harsh's question is very, very valid. The reason why I don't have inflammation in these images, we will learn them in detail when we come to your cardiac pathology. But just a clue here, this chest pain has been there for only 6 hours. 6 hours is very, very less time for inflammation to come inside. Inflammation in heart attack comes after a day. At least I need 24 hours, 1 to 2, 3 days. I need for my inflammation to settle and become more. That's why no inflammation. Also, I'm going to think of an heart attack. Okay. Which part, Sahil? See, I'll look at the history part. It's a chest pain, ventricular myocardial biopsy, and the patient died. And the heart biopsy. If you look at this heart biopsy, you're not seeing any blue color in this area. It's only pink in color. The only point against necrosis here, like Harsh said, is the neutrophils. Neutrophils will not come till a day after infarct. It needs time for it to come inside, right? So this is very, very early. I'm seeing only pink area. It's necrotic area. So my question here is myocardial infarction. And amongst the four options, autoimmunity will not cause heart attack. Blunt chest trauma will not cause heart attack. The only thing which can cause heart attack is arterial thrombus. Clear? Harsh, I hope I cleared it out. And Sahil, I hope it's clear. Fine. Okay, I'll go to the next question. Read the question and I want you guys to comment. It's fine if you are right or wrong, doesn't matter, but just comment on the answer. 11-year-old with hepatitis A experiences nausea something. Examination, mild pain is there, tenderness, scleral interest. That's fine. Lab finding shows AST, ALT levels and bilirubin 5.1. Which of her lab findings is due to which of the following thing? I'll give you a very simple clue here. Let's assume that this AST and ALT is elevated. The question is asking, what is the reason for AST ALT elevation? That's all. What do you think is the reason for AST ALT elevation? The reason for AST ALT elevation is, we learned in necrosis, the reason why enzymes come outside is the cell membrane defects. Right? The cell membrane rupture. That's why the troponin came in infarction and the AST ALT level comes out in your liver. Right? Or in hepatitis. Here is my hepatitis A, right? Perfect, right? It's a very simple question, right? It's a simple question. This question came in JIBMA exam. It's not due to lysosomal autophagy, it's due to cell membrane defects, right? Okay, that's due to cell membrane defects. I think you are saying lysosomal autophagy because I know where you have read. You might have read this question before. It's due to cell membrane defect, not due to lysosomal autophagy, right? Because if it's autophagy, the cell membrane is not damaged. The autophagy is not complete death, it's a dormant stage. Okay? It eats and stores inside, it will not release them outside, right? So when something is coming outside, the cell membrane ruptures. Due to the cell membrane rupture only, it will exit outside. Because it's a blood test, I'm doing the serum, right? It's option A, not option B, right? I hope that's clear. Do you guys have any doubts? It's not a doubt, we will call it a day for today. So today, just to sum up, we have learned about atrophy, the one which we left yesterday, and we have covered in everything about necrosis. Fine. So in yes, it's hepatitis, Osama. So in the next class, you will have microbiology for the next 2 days. When next I come, I'll go to apoptosis, other forms of cell death, autophagy, and everything. Fine. The classical case of hepatitis, and hepatitis definitely will have necrosis. And when there is necrosis, it results in release of all the contents outside. Right. Hepatitis will have necrosis. Don't worry about it. We'll learn what type of necrosis when we come to the other forms of cell death. Right. Okay. Okay, great. Thank you so much for your time and see you soon. Harsh, I would say if you are in second year, the three versions of Robbins, I don't know what versions you're talking about. There's a book called as Pathologic Basis of Disease. I think that's the biggest book available. So read that. If you feel that is difficult, it's not difficult, it's easy only. If you feel that's difficult, there's one more book called as Basic Pathology. The Basic Pathology is a concise version. I would feel an undergraduate can read Pathological Basic of Disease. If not possible, Basic Pathology. I don't know what's the third version. Don't read that. Fine. These are two versions. Go with the first version. That's the best one. If not, the second version, Basic Pathology. Right? Thank you, Sama. Okay, so today we swim through without any technical fault. Thank you so much for your time and efforts, and we'll see you soon. And we'll learn back pathology in the next week. See you then. Bye bye.